On this episode of the ASC Podcast with John Goehle, we catch up on all the recent news, discuss recommendations for treating patients, staff, and family members in the new normal, get an update on the Paycheck Protection Program Changes, discuss survey activity, discuss the future of ASCs post-COVID, and some of the financial challenges that they will face with a panel discussion with Brian James and Tracey Chadwell with Intalere.
This episode of the ASC Podcast with John Goehle is sponsored by Intalere. Intalere empowers healthcare organizations to elevate their clinical, operational, and financial performance with their GPO services, performance solutions, advisory services, strategies, and programs. For more information, visit their website at intalere.com. That's INTALERE.com. Welcome to episode 107 of the ASC Podcast with John Goehle for June 15th, 2020, recording from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me from our studio in Spencerport is John Goehle, recognized as one of the nation's leading experts in the ambulatory surgery industry.
Well, we're back in the studio. We are actually doing a regular episode instead of a live episode, which means that you get to edit out all the kerfluffles. Is that a word, kerfluffles?
I don't know. If not, I'll just
You'll edit that out.
I know it's been a while since we've done
it's been almost
one.
2 weeks. So, since we've done any episodes. And we do recognize to our adoring audience out there that we're running a little bit behind schedule. So we're going to start trying to get caught up. And quite frankly, the main reason for this is because we are just so busy right now. Our New York City facilities opened up last week for elective procedures. And you went on the road. You started on the road last week, actually. Made your first trip out in 3 months, 2.5 months, something like that.
Yep.
And I go out on Thursday myself. So and then I think by next week we actually start having a somewhat regular schedule. We're not going to be on the road like as much as I was before because, so many things have changed too now that we're using, I hate to say the brand name, but Zoom for just about everything. I spend most of my day on Zoom for various things today.
It seems like it, doesn't it?
I
I think it works very well. I think sometimes people then focus in on that this is the meeting time. It's just, it almost sometimes seems more efficient and more beneficial to everybody.
Yeah, and our company, Ambulatory Healthcare Strategies, we actually have a morning meeting, which unfortunately goes on for way too long.
Yeah, some of that is people being lonely at home.
I know.
So sometimes we're kind of...
Definitely.
Sometimes it veers off a little bit.
Yeah, definitely. Well, we have a lot to cover today. I just want to talk a little bit about the structure of the episode. We're going to, for the first segment, one we're in right now, we're going to talk about some updates on the news. The second segment, we're going to have a panel discussion about ASCs and their financial future. We're going to have a discussion with two individuals from Intalere. And for the third segment, since there's not much to report in the way of conferences coming up, we're going to use that segment for talk about things going on in New York State and California. And we have been very busy with virtual conferences. As anybody that follows us knows, I've lost track of the number of them. We just finished up our last one for a while on Friday, and that was a 2-day financial conference. And unfortunately, in the process, I broke my brand new camera.
Well, you didn't break your camera.
Well, I don't know. It wasn't working. I can't totally blame it on the puppy. But, it wasn't working. I moved it out of the way, and then she tripped on it as she was walking out of the the place. And she feels very guilty about it. I know that. But I do think that it wasn't working. I waited 3 months for that camera, so I'm kind of sad. So I'm back. Of course, you don't see us, but we use the our podcast audience doesn't see us, but we use those cameras for the virtual conferences. And to that end, I just we have a lot of virtual conferences now that are out there that might be useful to you. So I just wanted to kind of point to a couple of them that you might find helpful. Probably the most useful right now is the Infection Control Coordinator training session, which we recorded. I think that was back in April. And it's either for a new coordinator or for existing coordinators that need to demonstrate their ongoing training. So if you are an infection control coordinator in a surgery center, or if you have become appointed as an infection control coordinator, first of all, congratulations. And you probably are going to need some training. Well, you do need some specific training that to demonstrate to CMS or to surveyors that you have been trained in ambulatory surgery center infection control. So it's very reasonable price. It's a video training now. It's I think a 6-hour training program that we did again in April. It's $199.99 and it's available on our website at ascpodcast.com. And remember, now more than ever, surveyors are going to be looking for documented ASC specific training. So at the end of this training, you provide us with the codes that are embedded in the training, and we'll send you a certificate to indicate that you've listened to the whole thing through. Mm-hmm. And when you purchase access, you get access for 6 months. You can listen to it an unlimited number of times, and it does come with the slides. You have to send me an email after you purchase it, and then I'll email you the slides for it. And at the end, as I said, you get a certificate that you can use once you send the codes in, and it can be what I recommend you do is you take the slides, you print the slides off, and then the certificate that we send you and put it into your infection control binder to demonstrate that you've gone through the training. So, and the training was done by, I moderated the session, but it was done by my dear friend and Ambulatory Healthcare Strategies infection control consultant, Lori Rodericks. So it was I thought it was pretty entertaining, nice interaction.
Yeah,
it was different than, it's not a webinar. That's the thing you need to remember with all of our virtual conferences is that there's humor. Sometimes a puppy shows up. At that point, she was quite young. She's grown up quite a bit since then, but just recognize that it's not your normal training, and it means a little rough sometimes. Sometimes things go wrong during those recordings, but I think that kind of gives us a little bit of a live flavor. The second thing that you might want to look at is an in-service that we prepared last month at the end of May for your staff on how to deal with COVID-19 in the ASC setting. And it can actually be used for our clients that are office-based surgery or some of the clinics too, but there definitely was a bit of a focus on surgery settings or procedural settings. It is long. It's about 6 hours long, if I remember right, maybe 5.5 hours, but it's very detailed training that you can use to demonstrate that you have updated your staff on how to deal with patients in the new normal. And you don't have to watch it all at once. And by the way, this is $99.99. You can access it for 6 months, an unlimited number of times. It also comes with the slides. And what I recommend you do is you kind of have it running perhaps in your staff lounge, and that way people can watch it as they go through. Because I'm sure instead of having lunch, people would love to listen to this training. Sue's giving me this like, are you crazy look here. See, that's why I miss having the video here, is people can't see the facial expressions that you lob at me all the time. It's probably just as well. So again, that's an in-service for staff on COVID-19. And one of the things we're going to talk about in a few minutes is that certainly that's going to be one of the things that surveyors are going to be looking for is demonstrated ongoing training. And I mean ongoing training about COVID-19. And then we also did a mandatory annual training program. That was, I think, mid-May. That's a training that really doesn't have anything specifically to do with COVID-19 at all. It was training for all of your staff needs. Every year, you know that you have to do mandatory training, and that comes in two flavors. One is training that everybody has to go through and can be done for any surgery center, and then the other one is surgery center-specific stuff. So if you're doing an annual mandatory training, you're going to have both this generic stuff like HIPAA, OSHA bloodborne pathogens, OSHA, and you'll have to demonstrate that they've been reminded of that, through the training program. And that's what we prepared here. As I said, it doesn't have any of the ASC specific training, but it does take care of at least probably about half of the mandatory annual training that you do. That price is also $99.99, and it can be accessed for 6 months. Also, unlimited number of times, and comes with the slides. And we're going to be updating that one every year. And if you need specific annual training for your staff, just contact me at 585-594-1167. And we'll arrange to have training recorded for you. And then we have a couple other conferences that I'm not going to go into details here. We had the New World Conference, which was a 2-day conference, kind of similar to an in-person conference, except it was all recorded. A lot of fun, good topics, about 14 credit hours, I believe, of AEUs. We just finished the Finance, Accounting, and Reimbursement Conference last week, which will be available soon. I guess I better get to work on the recording there. I feel like a movie producer now because I have to use a program called iMovie, which is part of the Macs, and I take all of the recordings and I edit it and I add music and I do all this great stuff.
You've gotten very good at that.
Yeah, I think. Do you think I might be eligible for the Academy Awards?
You never know.
Yeah, I think you look good on the carpet there if you're following me. And then there's the ASC Roadmap to Recovery. You're kind of skeptical there, huh? The ASC Roadmap to Recovery, which gives you an overview of what to do to prepare for the new world. And it's basically for managers, kind of, how do you deal with this new normal, shall we say? We keep referring to that term, the new normal. And that's available. Again, all of these things are available on our website at ascpodcast.com. I guess we haven't turned all of our camera or our cell phones off. I have not turned my... I thought yours went off.
Nope. We all have to remind John to turn off the phone.
And you also promised me that you're not going to be doing as much editing when you edit this at the end here. So maybe we'll get this out a little bit sooner. Actually, we recorded the interview last week. It's been taking us a while to get to this. So let's talk a little bit about some of the recent news. Maybe we'll just alternate on this one, Sue. So the ASCA 2020 Virtual Conference and Expo is July 9th and 10th. This replaces ASCA 2020. Boy, I really missed that. That would have been a nice trip to Orlando last month. And it'd be the first conference that I've missed. Well, all of us missed in 30 years. This would have been my 30th year there. For more than 2 decades, ASCA's annual conferences remain the premier can't-miss event for the ASC community, and this year's virtual conference is no different. Just like ASCA's in-person events, the ASCA 2020 Virtual Conference and Expo offers nearly 50 educational sessions, access to more than 100 exhibitors, and unique virtual networking opportunities with hundreds of your peers. Go to ascassociation.org for more information. I did 2 sessions. I recorded those sessions probably about 3 or 4 weeks ago, and I have to be there live. I think mine are on July 9th. And as you watch them, I'm sure everybody listening will be watching those. And you can actually see me. So they did record me with our green screen. I don't remember what I put on in the background, but it was kind of nice. And you'll be able to type in questions to me, and I'll be answering those questions live by typing the answer back. Not as fun as actually answering in person, but it's the best we can do right now.
ASCA has produced a set of recommendations for COVID-19. Hopefully people have kind of figured out by now that things are not going to go back to normal anytime soon.
Unfortunately, I think all of the doctors have figured that out, because we're already starting to see people, some of the doctors saying they're asking when this month am I going to be back to my full volume, and we're trying to say there's no end in sight to this.
So ASCA has put together some notes about how to protect staff and patients, and it probably will become the standard of care.
I think that's an important thing to remember here is remember that even when something doesn't show up in the CMS regulations or the interpretive guidelines or in the AAAHC or the Joint Commission standards, that doesn't mean that you aren't required to do them. If it is the standard of care, that's one of the requirements for the standards is that if it has become the standard of care, then you can get cited for that. So as you said, there was some recommendations that they had. So let's just go through these recommendations, which are based on the CDC recommendations.
Okay, so to help ASCs protect patients and families, their surgical staff, and the U.S. population from COVID-19, ASCA is sharing some of the following recommendations. Pre-screen all patients for symptoms or high-risk exposure prior to their visit, beginning at the physician's office and during any pre-admission phone calls or other remote methods. Inform the patient to call ahead and discuss the need to reschedule their appointment if they do develop symptoms of a respiratory infection or any of those other symptoms that we screen for.
Right. And by the way, I'll include links in our show notes. Please look at the show notes after this one because there's going to be a lot of links in there to both the ASCA recommendation, which you don't have to be a member to access that, as well as the CDC recommendations. And then upon arrival, but prior to admission, patients should again be asked about a personal history of fever, sore throat, cough, or other respiratory symptoms and about similar symptoms in family members or close contacts. The body temperature of the patient should be checked upon arrival, and also ask also about contact with confirmed cases of COVID-19 or recent travel to a high-risk area. And one thing we should note, be very careful here because what we're recommending is that you actually don't write that temperature down on the log when somebody comes in, because that would probably be a violation of HIPAA. So we recommend
It would go on the patient's chart.
It should go right. I'm sorry. That's right. This is for patients.
This is for patients, but it's a good point to bring up though. When you're screening staff or visitors, you just want to check off in your log that they're below the required temperature. You don't want to put the exact temperature or exact symptom. That's right. And you want to prohibit individuals, including the patients, from entering the facility if they are experiencing elevated temperature or a symptom suggestive of COVID-19.
Keep patients and accompanying visitors separated by 3 to 6 feet. By the way, it's the first time I've seen the 3 feet there. I thought it was always 6 feet.
Me too. I wonder if, I don't know.
So separated 3 to 6 feet apart during their time at the ASC, provide supplies such as tissues, alcohol-based hand rub, and trash cans, and encourage frequent hand washing. If space is limited, ask patients and caregivers to wait in their cars until they are needed in the facility. If toys, reading materials, and other communal objects are located, remove them or clean them regularly. I can't imagine how you can clean I just don't see that happening. I think really you're going to have to remove those things. So those poor children coming in are not going to have any toys to play with, but it's our new normal.
All visitors, including vendors, should be actively assessed for fever and respiratory symptoms upon entry to the facility. If fever or respiratory symptoms are present, visitors should not be allowed entry into the facility. Determine the threshold at which screening of visitors entering the facility will be initiated and at what point screening will escalate from passive, like a sign at the entrance to the center, to active, in other words, direct questioning to restrict visitors to the facility. If visitors are limited, encourage use of alternative mechanisms for patient and visitor interaction, such as video call applications on cell phones or tablets. So maybe having people wait in the car or something,
if you can.
If you can do that.
Yeah, we know we have a lot of urban clients, and I know this is going to be challenging, but we'll do what we have to do. And I really think that comment about vendors, first of all, I think this is a good excuse to make sure the vendors are not there. I've never been a big fan of having a lot of vendors in the surgery center, so now we can just say that they shouldn't be there. And I think a lot of vendors. Well, the problem is that vendors are trying to sell you stuff when they're in the room, and we just have to be very careful about that. We actually talked about that in the interview a little bit later on.
And something that Jenna had brought up also is, as it gets to be warmer out, it may not be safe for people to sit in the car waiting for someone if they're, especially if they're elderly or something like that. So there's a lot of things to take into consideration.
Yeah, and I had recommended a lot of our centers that are not in urban areas, you can probably pitch a tent outside or something in order to kind of put them underneath it. And of course, in your waiting area, find ways to socially distance, try to spread out the population, and really carefully monitor or time patients coming in too.
And part of this is letting people know this on the pre-appointment phone call, because often people can get their own way there, and they just, as long as they know ahead of time, they can plan something.
Make sure appropriate personal protective equipment, PPE, gloves, mask, eye shield, goggles, face shields, and goggles available and worn by healthcare providers based on their job description. Ensure that healthcare provider is educated and trained and has practiced the appropriate and correct use of PPE, including the removal of such equipment. And this is really critical here. Again, as we mentioned earlier, we do have that training session for COVID-19, which I would literally just loop it. And I know you probably think I'm crazy, but, in the staff lounge, just to kind of constantly have that reminder out there. There's just so much to remember. And some of our clients have said, I can't sit my employees down for 6 hours. Well, don't do it all at once then. Just have it going in the background there. And, it is what we have to do in order to kind of get ourselves prepared or to deal with our new normal.
I would want to caution you to be careful, though, because lunchtime, break time has to be work-free time. There's some really strong regulations for that. So, if they have some downtime at work, but it's not their lunchtime, then that's the time to
I stand corrected.
That.
Though, again, it can be going, like during a break. Breaks are it's the lunchtime that is that they can't be doing anything else, but during breaks they can. So if and there's a lot of time in between procedures, and maybe there's going to be downtime. Well, there is going to be downtime because of the way things are going.
Go take a listen to that while you've got a few minutes. And conservation and strategies for optimizing the supply of PPE is critical. Only essential personnel should be present in all cases. Strategies and options to optimize supplies of PPE can be found at the CDC website. We will put a link to that.
Right. And unfortunately, this is a time frame where I'm afraid we're not going to be allowing students coming in during this time. I'm very sad about this because I feel so important that it's such an important thing for them to be able to experience it. But at least until further notice, we just can't risk that. This is something I think that we've been talking about a little bit within the company, is considering phone follow-up for all patients 7 to 14 days post-procedure to ask about the development of symptoms or a diagnosis of COVID-19 and have contingency plans in place, including public health authority reporting when a positive result is confirmed. The facility should follow the advice of the public health authority on notifying other patients and families who may have been exposed to a patient or family member who subsequently is diagnosed with COVID-19. So this kind of happened to you last week. You were visiting one of our centers, and then afterwards you found out that, or they found out that
a family member of an employee had tested positive. Yeah.
By the way, did you get the results back? I never even talked to you, so we're still waiting for those results. But no, this is a common question because I think at least once a day I get a call from one of our many clients who have had a positive result, be it a patient or a family member. And the same question is always asked, what do we do? The first thing you do is contact your local health department. You're not responsible for reporting that a test came back. You are responsible for reporting when somebody in your facility has had that exposure, just like you've always had to with communicable diseases.
And conduct frequent educational meetings, including refresher training for staff regarding infection prevention and related precautionary practices. Staff should be screened per ASC policies that are consistent with public health guidance for symptoms of COVID-19. They should not come to work with symptoms and should contact their personal physician. And that's what we were speaking about a little bit earlier, is that, have that screening logs to prove you're screening people every day, and just have, a column maybe that says under 100 or 100.4, whatever it is you're choosing, and just check that off rather than writing in their actual temperature.
And again, maybe because we're an educational organization and that's what we do with the ASC Podcast, let's just continue to emphasize the importance of those frequent educational meetings and refresher training. This is a time for your infection control coordinator to be actively involved in this. We need to demonstrate, by the way, one of the things that surveyors, I'll be asking more. I'll start surveying again, I think, in July. One of the questions I'm going to be asking is, how many hours per week is your infection control coordinator working on infection control stuff? And then also in their binder, there should be examples of the in-services that they're doing. Again, we prepared some tools for you, with the educational in-service that's available on ascpodcast.com. But you really need to demonstrate that person is not just occasionally doing stuff for infection control. They have to have an ongoing responsibility in that area.
And as you said, we'll be posting links in the show notes. And just a couple points of interest in the June 11th Outpatient Surgery magazine from AORN. According to researchers with COVID Surge Collaborative, during the 12-week peak of the pandemic, more than 4 million operations were canceled in the U.S. and more than 28.4 million worldwide. An AORN survey showed that the specialties with the highest case volumes as the country ramps up our general surgery, orthopedics, and urology. And this I thought was interesting. More than half of the survey respondents said that up to 40% of their patients have canceled elective procedures, but surgery centers reported the lowest cancellation rates.
That is interesting, yeah. Well, I think people are just afraid to be in hospitals now. One of our employees, her husband, actually had a stroke. And, the first question I had is, is he out of the hospital now?
Yeah.
I mean, obviously I wanted to be well, but it's funny that I was
more afraid of being
in a hospital.
And
at
around
this time.
here, we're not doing too badly, but still there is that fear.
Yeah. So that is interesting. And, one of the concerns that I have coming out of this, too, is that the delays in, like in the outpatient surgery centers, the delays in cancer screenings.
Yes. And cancer treatments. That's more hospital-based, but just...
And I also know from my past history that a lot of our, when I was running a surgery center here in Rochester, I had, probably one transfer a month. And the transfers were almost exclusively because the patient showed up with some type of a cardiac problem. I ran an eye surgery center and also did a GI procedure, so the patients were older. Yeah. But, one per month where a person would come in with a cardiac problem that we transferred to the hospital for a cardiac follow-up. Yeah. And, again, I think we did a great public service by getting that patient to the hospital, but I think people are withholding that. We also know that from looking at the statistics that the two populations that are most endangered with COVID-19 are those with a cardiac history and those with obesity. So again, if you haven't gone through cardiac screening recently and have any symptoms at all, you really need to get in. Please don't hold off on that. I'm very concerned about what's going to happen in the future. Near future with regard to this lack of cancer screening and cardiac screening.
And especially with cardiac things, people are always in denial. And if you've got this added thing on top of not wanting to go to the hospital, it will be very easy for people just to say, I'll get a check later. And sometimes it can't wait.
I will say one thing. People like myself, I don't know if I guess I am different, but, I'm taking my temperature 3 times a day. You and I are both monitoring.
You're a numbers guy. So
yeah, I'm a numbers guy. It's got to graph it.
Yeah.
And also, because we know one of the other signings is blood oxygen.
Yeah, low oxygen levels.
Pulse oximetry.
So,
So we monitor ourselves, 2 to 3 times a day on that, and we do take our blood pressure more frequently.
I check mine a couple times a week. But yes, you do check yours.
I got to graph it. But I think, I feel a little bit safer now just having this data and knowing this, and that's certainly not something I did before. But again, I'm concerned about, the clients that we meet. Both you and I have elderly, we have seasoned parents, mothers.
Yes,
and so you were very careful about that. You have another article.
Also in that same issue of Outpatient Surgery Magazine, they were discussing the new or maybe renewed debate between CRNAs and anesthesiologists. So after CMS's recent temporary suspension of the requirement for physician supervision of CRNAs, which allowed nurse anesthetists to independently staff ICUs and ORs during the pandemic, the Association of Nurse Anesthetists, or AANA, requested Secretary Alex Azar to permanently remove those requirements.
So just a little bit of background on this. In only some states are CRNAs allowed to practice independently, which means that in most states, a physician has to sign off on their pre-op assessment and supervise them during the procedure. I think everybody knows this. But during during the pandemic, they were allowed to practice independently. Now, we're that was a temporary suspension, so that's going to go back to where we were before, unless a permanent solution is derived from this. So stay tuned for that. We'll keep you informed as to what's going on.
So just to finish that up, the AANA has been pushing to end physician supervision of CRNAs for decades, and they wrote permanently removing these barriers will increase competition, network adequacy, and make much needed reforms to the healthcare system. So again, like you said,
and I think one of the big impacts is going to be on the rural areas where it's very difficult to get anesthesiologists. Well, I think it's difficult to get CRNAs out there too,
true.
But definitely that could help. And my experience with CRNAs has been very good generally. So I guess I'm pretty supportive of this myself.
And I saw a few articles giving kudos to the ASC industry, and I felt like we could all use a pat on the back right now. So in Becker's ASC review from June 9th, Dr. Shakil Ahmed, the CEO of Atlas Surgical Group, discussed how 2 of the most important factors in healthcare, especially in the time of COVID-19, are costs and infection rates. And he pointed out that ASCs excel in both of those areas. In the June 10th article from Fierce Healthcare, written by Tom Scott, the CFO of HST, noted that hospitals can work with ASCs as they work through patient backlogs in elective surgery. They also noted the cost savings and reduced risk of infection. And this is a quote: "As we climb out of this unprecedented crisis, health systems can take a variety of steps to best utilize ASCs as partners in addressing the backlog of patient care efficiently and cost effectively. This will help manage costs across the patient population, responsibly manage resources through careful planning, prioritization, and tracking, and minimize patient risk exposure in hospitals," which I think are all good points. Mm-hmm. And an article in York Daily Record, written by Steve Groff, MD, the founder of Orthopedic Spine and Sports Medicine and Pharmacy Health, focuses on the challenges facing surgery centers with the shutdowns and the reduced volumes due to the pandemic. So he's advocating for Congress to offer assistance to the ASC industry. And I'm just going to quote right from the article with this. ASCs serve a critical function in the country's routine healthcare operations. Under normal circumstances, these facilities provide an effective, lower-cost option for surgical procedures. Unsurprisingly, they have seen a sharp decrease in routine, scheduled, and elective surgeries. Many were among the first to donate PPE and equipment to hospitals to treat COVID-19, which I thought was a nice point. As the COVID-19 crisis subsides, ASCs will be an attractive option for patients that need a cost-effective location for medical procedures that they might be putting on hold. ASCs also hold the appeal of not being a hospital setting, reducing the risk of potential exposure. They can also help hospitals manage the expected surge in patients once they return to normal operations. So he feels Congress should be doing everything in its power to keep these centers open, but there's been little support for these vital facilities so far. Without relief, many ASCs will be closing their doors for good. We can't afford to lose ASCs neither in the short or long term. Keeping their doors open during the current crisis will save lives. Making sure they're around when the crisis passes will ensure we can actually provide care and services to patients in the years ahead. Losing either capability would be disastrous. So I felt like that was...
Yeah, and again, that's from the York Daily Record on June 8th.
Yes.
And it was titled, "Ambulatory Surgery Centers Are Closing. If Congress doesn't act, they might never come back." And that is just so true, again, by Steve Groff. That is so true. I'm very worried about the future. I mean, I think it can be very bright, right now, because we really have stepped up, and I think people are going to want to go away from hospitals. Are going to want to go to surgery centers. Exactly. But the problem is, financially, we're all small businesses. Look at our own company, for example. We're struggling during this time. We've expanded quite a bit during the time, but having the money, we're a small family-owned business. Both the podcast and ambulatory healthcare strategies are both small businesses. So we suffer just like everybody else has during this time frame. So I do hope something happens to step up. And to that end, the Paycheck Protection Program, the PPP, did get revised. On June 5th, President Trump signed the Paycheck Protection Program Flexibility Act of 2020. And these are the highlights. So the minimum maturity date for new PPP loans, those are loans that were taken out after the initial one, is now 5 years as compared to the 2-year maturity rate previously mandated. And then the bill extended the covered period for use of the loan proceeds from June 30th, in other words, the deadline, to December 31st, 2020, and extends the covered period for forgiveness from 8 weeks following the origination date of the loan to the earlier of 24 weeks following the origination date of the PPP loan, or December 31st, 2020. I think almost everybody's going to be that 24 weeks. So those of you that received the money originally, you had 8 weeks to use it up. And then any that was not used after the 8 weeks, you didn't have to pay it back right away, but you did have to pay it back, and the rest would hopefully be forgiven. So this is helpful. Our company actually got the Ppp funding, so just talk very briefly about that. We went through the 8 weeks. Our 8 weeks actually ends on Friday, and I think we're going to have a little bit of money left over. 'Cause we didn't pay out all of that money in the in the payroll. So now we have, instead of just 8 weeks to do it, we have 24 weeks, which will be good. So again, that's a big change for you. Those of you that did bring your employees back during that 8-week period, and if you didn't use it all. The bill also extends the time to rehire or readjust employee salaries in order to avoid a reduction in forgiveness from June 30th, 2020 to December 31st, 2020 also. And it also provides an exemption to the reduction in forgiveness caused by the reduction of the full-time equivalent employees with a number of stipulations. I'm not going to go into those, but you can read that. And again, we'll give you a link on the website to some more information. The bill further provides that borrowers must use at least 60% of their loan proceeds for payroll to be eligible for forgiveness. Those of you that remember, and we've talked about this before, it used to be 75%. Therefore, that they may use up to 40% of the loan amount for allowable non-payroll costs. By the way, this brings up an important point we should make, is that you really need to be listening to the most recent podcast to get the most up-to-date information. And we haven't put that disclaimer anywhere, but I'll try to put it on the website. Because things are just changing so rapidly.
Yeah, there is still some good information in some of the past ones, but always be aware of the date that you're listening.
In other words, listen to the podcast as soon as it comes
constantly.
out. That's right, 24/7. The bill also extends the payment deferment period. And finally, the bill amends that the CARES Act will allow employers to have PPP loan forgiven to also defer payment of their payroll taxes, which is previously prohibited. So a lot of changes there. Please keep up with that. And again, I'll put a link up there to the PPP reporting changes. I don't want to talk about N95 masks, but it's on our script here. So do you want to talk about it? I guess we can talk about it together. You don't want to, yes, she's shaking her head.
None of us want to talk about it.
None of us want to talk about it. I am really tired about it. We've talked about this a lot. There really is no change in the rules here. But I got another phone call today, somebody asking me whether they needed to do fit testing. Yes, you need to do fit testing. Well, so if you're using an N95 mask, if you have an N95 mask in your center, you need to do fit testing. You need to have a respiratory protection program. You need to do a health assessment on all the employees. And now, if you're opening up for elective procedures, you need to have a steady supply and recognize that if you're beginning to do elective surgery, as most of us are, it is that expectation that you're doing it without any exceptions. In other words, you're not reusing masks or recycling them or having them redone. So, and which means that once you remove it, you replace it. You could do, there were some exceptions allowed where you could use it for a week, or you could run it through a sterilizer.
Reprocess.
But if you're doing elective procedures now, you are no longer in those emergency times. So you should be following the OSHA rules verbatim. I think there's a lot of resources out there. I don't want to spend a lot of time on it. I'd say that every time I talk about them. But I just cannot emphasize this enough. These are OSHA rules, by the way, and violation of that could end up with 5-6-figure penalties. And we know that OSHA, by the way, is out surveying I'm not so sure about surgery centers yet, but they are surveying healthcare organizations. Let's finish the segment by talking about surveys and their reopening plans. AAAHC did announce on their website, again, I'll have a link specifically to this section, that they're going to begin surveys. They began them in June. I know that they're out actively looking for surveyors right now, myself included. And Lori, we have 3 surveyors right on our team. AAAHC will contact your organization if you have a lapsed accreditation due to a postponed survey. If you've submitted a completed application and accreditation is lapsed, submitted a completed application and scheduled survey was postponed and accreditation is not lapsed, submitted a completed application and accreditation is not lapsed, pending intracycle activity due to, for example, an interim survey, a special survey, or annual attestation. So we actually have all of those situations going among our clients right now. So we've seen a lot. I think in one day last week we had 8 or 9 letters from AAAHC asking for an update on what's going on. So when contacted by AAAHC, be prepared to share the following information. Any updates regarding the impact of COVID-19 on your operations, for example, your closures, your hospital conversion. There were very few people that converted their surgery center to a hospital. I think it was less than 15. Updates on organizational profile and on changes to operations related to COVID-19, for example, changed surgery days or hours of operations, and also staff. We've we've lost, unfortunately, lost meaning that they've resigned a number of our nurse administrators. So this has been a difficult time. Any actual or potential exposure of staff or patients to COVID-19, confirmation of the availability of PPE for surveyors. So don't expect them to bring their own PPE. They're expecting you to provide it. For organizations with an upcoming expiration date, you will be required to have submitted a completed application before your expiration date in order to prevent a lapse in accreditation. And of course, AAAHC will continue, both them and Joint Commission, which I'll talk about in a second, are continue to complete high priority emergency surveys for all the Medicare deemed status centers and all non-Medicare deemed status programs. And prioritized surveys include, all the discretionary ones that address immediate jeopardy complaints, initial MDS or Medicare deemed status or reaccreditation, initial MDS surveys if seeking a new CCN number, first-time accreditation, early option surveys, any revisits necessary to resolve current enforcement actions, and MDS or non-MDS reaccreditation surveys of organizations that have a history of immediate jeopardy related to infection controls. So get your applications in as soon as possible and, go to their website for any more information. Surveys will be heavily focused on infection control and your response to the COVID-19 and your preparedness for future issues. Joint Commission's website also has information. Regular surveys and reviews are to resume during the month of June or resume during the month of June with some changes to protect the safety of everybody. And they stated on their website they're committed to working closely with organizations with safety being the first and foremost priority as they begin to start that. So they're really reviewing the way they do surveys. So there's a lot of differences in the future. So for example, they're going to be limiting the number of individuals in group sessions. They're going to try to maximize the use of audio or video conference calls, which can be integrated into the organization's survey program, minimizing the number of people who accompany the surveyor on tracer activities. Using masks will be a routine practice, and we'll expect the organization to provide masks and other protective equipment, just like AAAHC. Maximizing the use of technology to eliminate the number of people to sit directly next to an individual for an extended period of time. For example, conducting electronic medical record reviews using screen sharing or displaying or projecting the record. Other examples include simulating an activity if you're unable to enter a high-risk space and interviewing patients or staff by phone. Driving in separate cars to off-site locations or home visits. That doesn't apply to us so much, but definitely they'll be using separate cars. And this was interesting. They do say that their survey will focus on a thorough assessment, will not retroactively review compliance. The implementation of an organization's emergency operations plan will not be the focus of a return survey activity considering the centers for the CMS waivers and other extensions. Rather, they're going to work to understand how you have adapted to the pandemic and review your current practices to assure that you're providing safe care and working in a safe environment. So there's a lot of resources that are available on their website, and really encourage you to go up there. Whoa, that was a lot of information. It's probably the longest first segment that we've had in a long time. So let's take a short break, and we'll come back and discuss some of our thoughts about where we're heading in the future on the financial side and have a panel discussion.
Who is Intalere, and what is a GPO? Intalere is a group purchasing organization, or GPO. A GPO is a company that saves you money on the things you need to buy for your healthcare organization. We do that by using the buying power of thousands of providers of all types and sizes to negotiate better prices from suppliers, manufacturers, and distributors, allowing our members to obtain the right products at the very best price for virtually everything they buy. GPOs do not buy or sell products. We simply work with your current suppliers to get you the lowest possible prices on the items you already purchase. Our 100,000 plus members nationwide currently have access to more than 1,400 contracts. This means by joining, you can immediately use that buying power to start saving on items like medical supplies, equipment, pharmaceuticals, telehealth solutions, and more. Membership is free, and Intalere's approach to helping our members enables you to determine how much you want to save. The more you connect with our GPO, the more you save, and it's very easy to get started. We have online resources that were designed with you in mind. We provide one-on-one support to get you up and running, connected, and implemented quickly. After that, we have ongoing customer support to help you on your journey to saving money. Besides saving you money, we also offer a variety of financial, operational, and clinical solutions. Every healthcare provider is different, so we have a wide breadth of options for you to choose from. So join us to start saving. Visit Intalere.com or contact our friendly customer service team at 877-711-5600 today.
So welcome back. And Sue, you and I last week, we interviewed Brian James and Tracey Chadwell with Intalere about the financial challenges that ASCs are going to face over the next year. And it was kind of a panel discussion. I noted you kind of dozed off when we started, talking dollars and cents here. Sue is a true nurse where she knows the importance of it, but would rather not talk about it. So I do appreciate that. But it was a great wide-ranging discussion. So let's listen to that interview now.
And in our focus segment, we're talking with Brian James and Tracey Chadwell with Intalere about financial issues.
Welcome. It's great to have you on a recorded podcast as opposed to the live podcast that we've been doing quite a bit lately, and to talk about a very important topic right now. How are we going to get through financially the rest of this year, and what types of financial challenges are we going to have? So I just wanted to open this up for a dialogue about what do you perceive to be the challenges that the ASCs will face over the next year. Both of you, of course, work on the supplier side of ambulatory surgery centers, and you're in touch with your centers on a regular basis. So I'm just kind of curious as to what types of issues you are coming up.
Well, I think for a while, certainly the first, since March, certainly it was PPE, pretty much 24/7. I think a lot of our members were just trying to keep their staffs intact during the downtime, trying to be as productive so that when things were opening back up, they would be better prepared for probably a very busy summer. And, really the things that we're hearing about is just making sure they're geared up with their supplies to open up. And, I think they're erring on the side of having too much versus not having enough. I think, and I don't know if there was even some built up purchases made, maybe not by surgery centers, but I think there was a little bit of hoarding going on for a while. And I think, that's kind of a two-edged sword, because if you have, it can throw off certainly your expense line and your carrying cost if you have too much inventory, and how to strike that balance.
Yeah, actually bring up a very good point that now more than ever, I'm always talking about how important it is to maintain and do periodic physical inventory so that you know how much is laying in stock there, as opposed to how much you've actually used up. When I do public speaking about finance and accounting, I'm always talking about the importance of keeping your inventory levels to the minimum that you need. And of course, I'm rethinking that completely now. Certainly, we know that our PPE, we're going to have to get to different levels. So I'm just kind of curious as to what the two of you feel we should be looking at, and what's reasonable. We don't want to encourage hoarding, but by the same token, we don't want to put ourselves in a situation where we're not prepared for the next situation that might occur.
Absolutely. And the other thing you're looking at too is space availability. So, if you're carrying it at an inventory, where are you going to put it? So, I think that contingency plans do need to be made. Some of the talk has been about going to reusables and having a plan behind that, where they can maybe do that for a certain period of time as using reusables.
Yeah.
Others are looking at ways to disinfect disposable products and use it that way. And I've even heard some state ASC groups talking about kind of a stockpile for their group and purchasing that. I don't know exactly what logistics they've come up with as far as storage and that type of thing, but some of them were even discussing about that, and then them allowing them to have access to that stockpile should something like this happen again. So I think it's going to be determined by a lot of other logistical issues like subspace and where they can put it, and then what's available. So, I think to me what makes the most sense, especially for an ASC arena, might be looking at like cloth gowns or something like that, going back to some of the reusable items, that they can at least, it reduces the number they'd have to have on hand, but they definitely have to have a plan for the laundering and that type of thing too. So I just think that's one viable option.
I guess another thing to add, just with my distribution background, is a lot of times the distributors try to keep them to a maybe 2-day a week delivery. I think that compounds the issue of trying to plan your inventory for upcoming procedures. They may want to ask their distributor just in the short term to increase their delivery days, or the days that they could order and get it the next day. Because I think that sometimes they're kind of pushed into a corner to try to plan too far ahead, and maybe some more flexibility and terms and conditions for the distributors would help.
An idea just came up right now. What are you seeing with regard to pricing? I've noticed just, personally, of course, grocery store prices are a lot higher. I don't have a sense of what's happening with regard to pricing, but are you seeing products costing more because of the types of issues that we've had to deal with over the last 3 months?
I would say yes. There's issues from pharmaceutical side as well as just the supply side. Depending on the availability of the raw materials for making them, is probably the biggest driving factor. And so I don't anticipate, I don't know if that'll last or what. One of the nice things about being part of a GPO is you do get some price protection. Now, again, with something like this, it doesn't always hold in an emergency situation. But that is kind of one of the things that, like I said, is the benefit of it. So we have a little bit more leverage, I guess you could say, with some of that. But we have gotten some notifications that there will be an increase in pricing in certain areas of PPE, specifically the gowns and the masks.
So there's been a lot of talk lately about shift the manufacturing from China to the United States. What areas do you think we're going to find shortages in? I mean, we know about the PPE, but about other areas that we should be keeping a very close eye on and making sure that we don't bring our inventory levels down too low.
I would think oxygen supplies, for oxygen delivery type issues, and pharmaceuticals. Brian, what's your thoughts?
Yeah, I guess this is where, again, back to distribution. I'm always going to kind of go back there, but your distributors, certainly the breadth of products that they offer. Some have a stronger, well built out private label, which a lot of private label is made abroad as well. But having some flexibility, I guess, in comparable products, and I think the distributors that have a wider breadth of products can, I guess, help offset some of the shortages. They have more options, I guess, to go to. And I think this is probably where smaller distributors may struggle during these times because of their lack of inventory or their lack of options, I guess, available to them.
So one of the things that I always talk about is maintaining less than 30 days in inventory right now. I think one of the questions that my audience might have is, okay, what is the proper number here? Okay, John, forget about what you used to say in the past because you're trying to keep the costs low. Now we're running the danger of not being able to do surgery if we don't keep those inventory levels at a certain level. What do you think in terms of supply chain in particular would be an appropriate level for the average surgery center?
I would say that, I guess the more advanced facilities out there certainly are adopting some sort of, or have adopted some sort of kind of materials management system that allows them to preference card and kind of order per case. Dr. Jones has 10 cases next week, and really probably planning out in 2-week increments around, but I have a feeling they're not going to have as much consistency, I guess, in that scheduling. So I think it's going to be very fluid, I guess, the demand for products, and, it's going to be tough to kind of predict how case flow is going to flow, I guess, in the future, which probably having some sort of type of system to manage that would be most effective.
Yeah, I think if you get a historical perspective on it to see what was being done in your normal average time, and then being able to kind of extrapolate what you think the need would be if you were having to use PPE for that, or have that have things on hand. The other thing that is going to be important to do is define what is considered as elective surgery, so that, again, when you get pushed to something like this and you have to cut back, you'll have that determination, too, of what would be considered elective and not appropriate to do at that time versus what would be considered emergent, and get those numbers as well. So if you were to be able to continue in that capacity doing more emergent procedures, you would at least know what it looked like historically and what kind of supplies you needed to do that and keep those running. So I think it's going to take a look back at what we used to do, and then our response to several different scenarios on what would be needed in that case, to determine what would be a good, reasonable number to have on hand for your PPE and other types of supplies.
And we have to be very careful here, too, because, again, we want to avoid the hoarding to the point where you have so much inventory that it actually expires before you're able to use it for those items that do expire. Right. So you're right, Tracey. I think being very careful with counting, with looking forward, pull out that old Excel spreadsheet there and start calculating doing some complex calculations there, or call your friendly neighborhood consultant to help you put those projections together. But you need to be very careful about this, because there's just as much danger that you're going to end up stuck with an awful lot of inventory, and doing a risk reward thing. I mean, you might decide that it's worthwhile for you to have higher inventories, even if you are going to end up having to throw some stuff out, because the risk of not being able to do a surgery and the cost of that might be so much higher. I mean, this is a completely different dynamic than we've had in the past here, and I think we have to think very innovatively here and be prepared for a future that would include the same type of crisis that we've already gone through again.
There's probably a broad assumption, which probably is a bad assumption to make at times, is most of the ASC industry using custom packs? I would assume that's kind of the standard protocol, from a facilitating, I guess, to pick for cases and whatnot. But I guess that would be almost a question out to the group: is there facilities still out there picking separate items for procedures, or are they all using custom packs, as a whole?
Well, and again, one of the dangers with the custom packs is you could end up with a bunch of products in there that have different expiration dates. You stock up and you have 3 months worth of supplies. Half of those items might expire. And I'm just making those numbers up, but some of them will expire, and you're going to end up having to take them apart anyway. So custom packs are great as long as you're not buying custom packs in huge quantities to be able to get past, to maintain an inventory of 2 or 3 months, I would think.
Yeah, and I think a lot of times the custom packs, they may not, and maybe they've learned the hard way, is not to put too many things that do expire, in those, and try to keep those separate. I guess that's usually where the distributor / pack manufacturer can help facilitate, what's the optimal. You have to go through a pack redesign. This may be a good time before they open up again, is to review, what they have in a pack.
That's a good point. Yeah.
Maybe a chance for them to reevaluate that as well.
Let's just shift our focus a little bit to infection control. We know from a regulatory standpoint, we know from a safety standpoint that infection control has never been more important than it is today. And Tracey, you and I have talked a little bit about some of the innovative products out there. And so one thing, first of all, I think we need to warn people is be very leery of anything that you are being sold until it becomes a proven technology. Just because somebody comes back and says this will solve all of your problems, don't go out and buy it. You and I were talking offline about a lot of the UV stuff, and I know you're looking into and researching that a bit, but I'm hoping nobody's gone out and bought the newest UV equipment just because somebody told them it was a good idea.
A consultant, right?
That's very true. Yeah.
So what do you think we should be keeping an eye on out right now? And I know this is kind of a premature question. I know you're looking into it, but if you can just give us some things to kind of keep an eye on.
Well, I think what's going to be really, really important is it's kind of not necessarily always the new products, but currently, again, ones that are approved or currently approved, because you may not have to go with anything new from a cleaning perspective. What is going to have to happen is the the IFUs and the information for the actual products and equipment need to be updated, because it says to not use products on stuff that's not recommended by manufacturers. So, if you're changing products and looking at that, that definitely has to be something considered, that you have to show at least that you've done some effort in making sure that you're complying with manufacturer specifications. I know there'll probably be some leeway with that, but that's going to be incredibly important. Some of this stuff is common sense. Some of the stuff we've been doing for years. We've just not always done it well or done it consistently. But I think some of the bigger things is going to maybe look at air handling, especially when we're looking at terms in the OR, and whether you have enough to your system's able to accommodate what's required to not have an terribly increased turnover times. So those things are going to be incredibly important. And again, even just looking at workflow considerations that are going to be more effective for your employees and for your patients. So I don't, like you said, UVC is it seems to be the big buzzword, and what's going to be, coming up with that. And that's probably the biggest thing I've seen. The other ones are more implementing different measures, to accommodate or make adjustments, I guess, for this new practices in our workflow, in our processes that we do, and how we do it, how often we do it, that type of thing. So I'm not seeing a terrible lot, from a perspective of actual products coming out. I'm not seeing a whole lot of anything new necessarily. They're all trying to prove that they can kill this virus, and the kill times and that kind of thing is what really needs to be paid attention to.
Yeah, I get emails every day about these products, and it is I pretty much put them into spam, but I think we just be very careful about that. And there is no replacement for really good, solid cleaning, doing your hand hygiene, doing all those things that we should have been doing all along, but now we're taking extra care and making sure now more than ever that we're reading those IFUs so that we know exactly what those products are able to do and then using them consistently. One of the things I think we should probably warn our listeners about too, there are a lot of fake products out there. I mean, I think if you're working through your friendly neighborhood GPO and your friendly neighborhood distributor, you probably don't have a danger. But, be very careful about those emails that come in saying, I can get you, 10 million N95 masks for $1.95. I mean, we literally ran into a situation recently where somebody was given a 20-page cut sheet. I think we talked about it on a previous podcast. 20-page cut sheet for an N95 mask that on the second page I could see there were ear loops on the N95. And I said, it might say it's an N95, but there's nowhere in there did it say that it was a NIOSH-approved product or an FDA-approved. So be very careful about that.
Oh, I've had some that actually said they had certificates and had a picture of the certificate, except that they don't award certificates. So,
that's actually what was happening on this one.
Out,
yeah, that's what happened. There were 5 certificates that were attached to it.
Oh, wow.
Right. And one of the things that's nice is you've seen a lot of professional organizations actually vetting out suppliers. I know that ARM did that. They went out and actually worked with another company and vetted suppliers out and then posted the ones that they vetted out on their website. So that's another thing, is to check with, your state association or the national association, because they've been trying to help in that respect to kind of identify those, to give you a leg up. And then there's also guidelines on how to vet out a supplier if you are doing it on your own. So those are resources that are available as well.
Great. Here's a question out of the blue. I've been approached recently. There's been an increase in these companies that consolidate maintenance services and try to package it together, almost like an insurance policy. Have you seen this yet? Is that something that that is included in your GPO contracts at this point? And can you, without speaking about any specific companies, is that something we should be looking for?
Yes.
Actually, I started researching one recently. Yeah, when on the HCP conference, ran into a couple, and so that is something definitely looking into, because they, like you said, they combine cleaning and equipment maintenance, and so it would be something to kind of have, and they customize it to what your need is. So,
and your price.
Definitely something to start looking at.
Right. You know your price up front, so there's really no surprise down the road. They're taking the risk rather than you taking the risk in terms of the total cost.
Yeah, and most of those programs are built off of where you really have the same service techs serving you.
Right.
It's someone kind of putting under an umbrella, managing, again, like you said, the risk part of it, but certainly the same level of service is provided.
Yeah, I think that's something we should keep our listeners up to date on as that develops, because that when I do financial projections, that's always one of the biggest line items is the maintenance contracts and maintenance expense.
That's what I've heard. Yeah, I heard it's probably in the top, two probably in spend.
I wanted to talk again, Tracey. You and I, just before we started, we hit the record button here. We were talking about insurance, and I think I mentioned that I just looked at my auto insurance bill and saw the whopping $20 rebate that I got for not driving for the past 2 months. And I posed the question to you, and I don't know that we have an answer here, but should we be talking to our malpractice insurance carrier if we weren't doing surgery for 2 months? Should we go back to them and say, should I get a rebate? Can I get a rebate for that, or should we just let them pile up the profits during that time frame?
I think like what you said earlier, the thing is if people are going to be ramping up and performing more procedures than ever, is it going to balance out?
Right.
Are we going to see, increase in that? So I think that might be the question. Like you said, even if you have that talk with them or the discussion with them, and then maybe, like you said, balance up at the end of the year and see what does happen if they're interested in looking at that to see if there's those opportunities. I think we should explore all possibilities. Right.
And that's to the point. Look at everything that's going on in your operation here innovatively and try to figure out if there's some opportunities that you have before. And what we were, Tracey and I are talking about is that at the end of the year, we'll know whether our volume is up or down. And then going back to the insurance company, and that could even be retrospective or prospective. Maybe your future premium is going to be based upon your past history there, at least for the next couple of years. So definitely asking them to revisit the volume would be a good strategy right now. Any other comments before I ask you the last questions? Any other areas that we should be looking at on finance?
Well, I guess kind of along that line is, not only malpractice insurance, but just it probably would be a good time to visit all the, insurance products that a facility may have. If they have it all with one broker, it's certainly a time to evaluate, maybe it's always good to go through it. Do I have the right coverage for the right price and doing some of that due diligence? And maybe this would be a good time to revisit all that.
Yeah, and if you don't have directors and officers liability coverage, I really recommend that it might be too late, but it's important to kind of get that coverage in place to protect the people that make the big decisions here, especially if we're called on the carpet for some of the decisions we made during the pandemic. And get to know your contracts so that you know what coverage you actually have out there and what the exclusions are.
I was going to say, I would also suggest this is a great time to look at your business office practices and the possibility of automating some of the practices that you're doing, because as things start up, and again, if you're increasing the number of patients that you're seeing, you're wanting to be able to get out your billing done quickly to get reimbursed to make up for that. Also for what you've lost during this time, making sure and getting those things up to date. But if you take a look at your practice, make them more efficient, you will be able to hopefully recoup, what you've lost and any additional gain that you're going to get from the increased scheduling. But like I said, an automating service, certain processes, having availability of patients being able to pay online, things making it easier for them as well, so that you can benefit, from that. And because right now your business office is going to get slammed after a little while here, and also like your pre-certifications, being able to get those done in a more timely manner. So I think they're looking at the whole operation, not just the clinical aspect is going to be very important for us right now. Yeah,
that actually brings up an interesting point. I just had a conversation yesterday with a company that factors receivables. Factoring means that the company comes in and offers you a discount off the value of your accounts receivable, and then takes the risk or some of the risk of the collections there. And the benefit is that you get quick cash coming in, and the cost, of course, is that you're not getting your full receivable at the end. But
acceleration.
Yeah. One of the concepts that we had here is that many of the people, or one of the concerns that we've had is that during the furloughing period, a lot of people were probably laid off, including people in the business office who might have been doing the billing or the follow-up. And they're going to be, as you said, Tracey, slammed just keeping current with all the new cases that are coming in, they might not have the time to go back or might not, might have to focus on those things that they know they're going to collect as opposed to those things that might not be easy to collect. So this might be the time to, number one, think about factoring. And number two, think about bringing in outside resources to help you during this time to collect the back stuff. In other words, maybe, hire somebody that does the old stuff while you focus on the new stuff, which is obviously a much more valuable thing. So again, kind of a one-time situation, but thinking innovatively about ways to solve your business office problems is definitely a benefit. Brian, you and I talk an awful lot all the time. I have a very long relationship with Intalere and the former name Amerinet. I won't even go into how many iterations we go back, but I just really kind of want to emphasize the importance of maintaining a relationship with the GPO, whether it's Intalere or somebody else, but having that ongoing relationship, making sure that they become your resource. And can we just talk a little bit about the value that a GPO brings to the organization, why you need to do it, and what the cost is, or I should say the lack thereof of a cost for bringing a GPO.
So the beauty about Intalere, and I can't speak for other GPOs, is there is no cost to become a member. The really only cost, I guess, or investment that you need to make is your time and engagement with your either local rep or anyone within the GPO organization. To, typically we can't provide any sort of value to you until we are provided data that allows us to analyze, where we can benefit, where we can help. And, that two-way engagement certainly is the key to the success of the impact for the member, to realize, the savings. Those that don't engage, there is no easy button in what we do, but certainly there's a huge benefit for those that do engage with us. And it really is taking that first step to, have a regular conversation with your GPO rep and making sure that, you're asking the questions of how else can you help me? Because I think that's where the magic happens with our most valuable customers, is that continued engagement.
Yeah, throughout this whole coronavirus, Brian and I have been talking regularly. So clearly, none of us were furloughed, and of course, we were dealing with some pretty important issues during this whole time. So the point being is that you might not have been able to get a hold of your distributor during the crisis, but you certainly should have been able to get a hold of your GPO and pre-planning for the recovery efforts. So hopefully that's a service that was available to you. I'm still amazed the number of places I walk into that, first of all, might not even know that what the term GPO stands for, and the value that comes from working with a group purchasing organization. So again, I encourage all of our listeners to immediately look into it, because they're really, you can be up and running no more than a week, right? It all depends upon how quickly you can sign those electronic documents to get those good prices. And a lot of times, actually, most of the times, you're probably not going to be changing what you're getting. You might be using the same distributor, just getting a price, based upon a GPO contract as opposed to the price that you negotiated on your own. And honestly, sometimes you might be able to negotiate a better price than the GPO was able to do. I think it's somewhat rare, but that is possible. But at least you have a GPO behind you, or a big organization behind you with a lot more purchasing power helping you through this process. And then lastly, I just really want to point out the importance of that contact, that local contact with your GPO, reaching out to them on an ongoing basis. You as an administrator need to make sure your purchasing people are constantly talking to them. Don't let the doctor's nephew sneak in and give you that good price on that product without checking with your GPO first to make sure that it really is a good price.
And we'll be the first to tell you that, if you're getting a certain price and we can't, beat that, certainly we'll be able to validate that. Right. You do have a good price and there's really no need to change, right, at least on that particular contract.
Well, it's been a pleasure speaking to you, as always. We'll have you on again, and probably in a month, kind of check in and see how things are going as everybody ramps up again.
Great. Thanks for having us, John.
Thank you.
So we're back for part 3. Normally in this section, we spend a lot of time talking about upcoming events. There really aren't a lot of them, so we'll talk about those at the end. But at the beginning of this year, we did start including in part 3 state-specific information. So we're going to give you an update on what's going on in New York. A lot of updates just happened in the last 24, 48 hours. We're recording this on Monday, June 15th. So if you're listening to this on Tuesday, June 16th, which I hope to have out there
it means I did a very quick editing job.
And then we're also going to talk about California and updates from CASA sent me an update. So first of all, elective surgery in New York. All of New York is now open for elective surgery, and in order to do so, centers must follow guidance that was provided by the Department of Health. Actually, updated guidance was provided on Sunday night. So that guidance actually included diagnostic and treatment centers that are not ASCs that do procedures, as well as office-based surgery practices. So I know that most of our audience is ASCs. Some ambulatory surgery centers also are affiliated with office-based practices. So recognize that this guidance is for both, and we will post a link to the guidance.
New York patient COVID 3 to 5 day testing, the test period, may now be extended from 3 days to 5 days prior to the surgery or procedure. Test results should be received and reviewed before conducting the surgery or procedure. So just a
little bit of background there is New York, in order to be able to do elective procedures, requires you to do COVID testing. And that originally the guidance was that it had to be for 3 days. It's not so much guidance, it's required. Yeah. So, but the guidance then expanded that to 5 days, saying that it could take up to 5 days. And that's what we were finding is a lot of centers were having some real problems getting in within that 3 day period.
Yeah, they wouldn't get the results back in time.
Right. The only exception to the above would be for non-scheduled emergent procedures where testing prior to surgery may not be feasible or possible. In this case, a thorough screening and history should be taken as well as an appropriate precautions. A test should be performed as soon as possible, and if positive, may result in the need for a healthcare worker exposure protocols to be followed. So this is pretty serious, and I've had some discussions today. I've had a pain management center come to me and say, "You got to be kidding me! We're required to do testing," and this particular individual indicated that they're not testing in their office doing these pain management procedures. And I pointed out that the guidance is pretty clear that you need to do it no matter where you're doing it. So this particular doctor is not happy at all, but I mean, it is the rules. And if you want to remain with a license in New York State, you're going to have to follow them. So for healthcare worker exposure protocols, you need to refer to the CDC guidance and New York State essential personnel protocols. And that information is available on our website at ASCPodcast.com.
And for N95s and PPE, they're clarifying that adequate PPE means that an ambulatory provider has at least a 7-day supply of PPE on hand, and the provider's supply chain can maintain that level to support outpatient surgeries and procedures without resorting to contingency or crisis capacity strategies. That's the important part there.
Right, and that's what we were talking about before, that which means that you can't be reusing them, you can't be re-sterilizing them, as we had talked about quite a bit during the last 3 months. So this means that if you're doing elective procedures and do not have enough PPE without doing reuse, extended use, or sterilization of it, then you should not be doing elective cases. And this means that when single-use PPE is removed or contaminated, it should be changed. So this could really put a cramp on your future there. And then I did get an update from my friends over at the California Association of Surgery Centers. As this is what they stated on their website. As we look to the future, it's becoming clear each day that having our annual in-person conference in September will not serve our members. And I'm quite sad about that because we always love going down there. It's our excuse to vacation down in Newport. We have a place in Newport Beach.
Yeah, it's a great conference, too.
Yeah, it is a great conference, and I was really looking forward to it. But so they have decided not to do that. The board of CASA has made the decision to move quickly, not waiting until September. So they're going to be providing educational resources now to California ASCs. They're going to be launching a virtual series of ASC recovery, navigating the new normal. And these interactive webinars will take place on a regular basis, followed by a virtual breakout groups that where you can discuss the topic and situations you are experiencing with your colleagues. And they realize that nothing can replace the dynamics of the conference, but they're excited to see the new opportunity to integrate technology and provide timely education. And the virtual series content is being pulled from from a recent survey that the CASA did of its members. What an incredible organization CASA is, by the way. They really do keep in touch. I think we get, New York does the same thing too, but they do daily, communication with their members. If you're not a member of CASA and you're in California, if you're not a member of the New York State Association in New York, please join them. I'll put links to that up there too, yes. So that you can become a member. Those organizations have really stepped up. And not that other states haven't, but our largest listener base, by the way, originally we mentioned these as our largest listener base comes from the most populous states in the country. And these are the states that I've had the most communication with. And we know that the information needs are changing rapidly. So CASA are hoping to give the ability to quickly adapt to our members' immediate needs. And I've been in touch with Beth, the executive director out there, about redoing one of the conferences I was going to do on finance out there. So we're working on that. In addition to their excellent education program, CASA has a history of connecting our ASCs to critical vendor partners. So they want to continue that tradition, and in the next coming months, they're going to be putting together a fast-paced virtual vendor meetings to assist with these vital connections. So be very interested to see how that happens. We're having that same challenge in New York, trying to figure out how to engage our vendor members of the New York State Association with our membership. This is going to be a very quick update on upcoming events. Sue, go ahead.
You're never alone in the ASC industry. Many organizations, or a few at this time, are eager to provide an opportunity to keep up on all aspects of running an ASC. And in this section, we highlight some upcoming events.
And I believe we only have 2. But if you would like your event to be included in the podcast, please send the event information to info@ascpodcast.com. So we will try to keep this updated. We haven't, because things are changing so rapidly, I only put 2 things in here that I know are going on.
Yeah, and obviously, if there's something that you're looking at or you're interested in, just keep checking their website or call the place before you assume, because a lot of places are going virtual or postponing.
And another thing to point out, too, is the ASC Podcast with John Goehle is available. We do have the technology. We have a studio to assist your state association if you wish in doing the virtual conference. There's no charge for that. So just get in touch with me at info@ascpodcast.com or call me at 585-594-1167. We'll be glad to help out. All we ask, of course, is some recognition for the podcast. We have this wonderful technology. We have this wonderful studio, albeit with one less camera. We have a puppy that we can throw on every once in a while in order to lighten things up. But I think we've become very good about doing these virtual conferences, and we'd be glad to make it available to everybody.
So ASCA 2020 transitions to virtual conference and expo.
As we talked about earlier.
Yep. The ASCA 2020 virtual conference and expo, scheduled for July 9th and 10th, will offer the same quality education, networking, and resources as ASCA's in-person events, all from the safety and comfort of your home or office.
So for more information, go to ascassociation.com. And the Ohio State Association Conference is still scheduled live for September 30th through October 1st, 2020 at the Hilton Columbus Polaris in Columbus, Ohio. Keep on in touch, or keep going to that website if you are in Ohio to see if there's any changes to that. We are signed up. I believe I'm doing a session out there, and we are going to be vendors there. So hopefully, I don't even know what to say. It's hard to say whether, things will be available for in-person events at that time. Of course, they're in the middle of the country, so a little bit different out there, but still everything is up in the air. So that's it for this episode of the ASC Podcast with John Goehle. Join us again, and please consider becoming a patron by going to our website at ascpodcast.com and spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. I do want to point out that I've made a number of updates to our patron website, included a lot of new content up there, including a respiratory protection program that's available for no charge it's available for anybody that is a patron member of the ASC Podcast with John Goehle. So just follow the links on our website, and you can become a member yourself. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Kalritis, and Lori Rodericks. Music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved.